Okay, we'll continue with our discussion of the guidelines. This podcast will address B3.6a through B3.16 and building an ICD-10 PCS code. B3.6a talks about non-coronary bypasses. A lot of us have heard of the coronary bypass, like we do for people having trouble with their heart. This particular guideline addresses non-coronary bypasses because there are times when, for example, we might bypass a portion of the intestine because it has cancer in it, and you're going to bypass that part of the colon and actually hook up to a different section, which is the example that I have here. The guideline states bypass procedures are coded by identifying the body part bypassed from and the body part bypassed to. The fourth character, you can see in the little blue box there, is the bypass from, and the seventh character, the qualifier, is the body part bypassed to. So the example I've given, where you've got a bypass from the stomach to the jejunum, you are bypassing the duodenum there. So you're going to have your body part bypass from the stomach is your fourth character, and your body part bypassed to the jejunum is your seventh character. This particular guideline is just for non-coronary bypasses. You see in the table where I have written bypass from by the fourth character and bypass to in the seventh character. The next guideline, B3.6b, is addressing coronary artery bypass procedures. And it tells us that coronary artery bypass procedures are coded differently than other bypass procedures. Rather than identifying the body part bypassed from, the body part, or character number 4, identifies the number of coronary arteries bypassed to, and the qualifier, the seventh character, specifies the vessel bypassed from. You can see in my screenshot there how I've written that at the top of those columns. And you're only going to use that particular guideline when you're doing a bypass. So the root operation bypass, you see there at the very top, we're in the heart and great vessel body system. Bypass is your root operation. That particular table is where you're going to write character 4 is the number of coronary arteries bypassed to, and the qualifier bypass from. And you see, of course, all my notes. I keep a lot of notes in my code book. You can either keep them in your code book or have a separate notebook where you keep notes, but you will have to have something because there's always information coming up either through Coding Clinic or things that you discover on your own when you're doing research that you need to remember or want to remember. So here's an example of this guideline where you've got an aortocoronary bypass of the left anterior descending coronary artery and the obtuse marginal coronary artery using zooplastic tissue. And you see the fourth character body part is our coronary artery, and it's two arteries. We mentioned the left anterior descending and the obtuse marginal. Open approach almost always on a bypass, if not always. And the device, we're going to use a plastic tissue, which you may recall is of animal origin, and it's bypassed from the aorta. So here you see the PCS code, you see my table, my notes. If multiple coronary arteries are bypassed, a separate procedure is coded for each artery that uses a different device and or qualifier. In other words, you're specifically looking at the 6th and 7th characters and seeing if the device and the qualifier differ between those different arteries. Here's an example where you're doing an aortic coronary artery bypass and an internal mammary coronary artery bypass. They are coded separately because the 7th character position is different for aorta and for internal mammary. And you have to code those two codes because the 7th character is different. I mentioned this before, I'll tell you again, watch these more than once because they make more sense the more and more you watch them and the more and more you read them. The next guideline is B3.7, control versus a more definitive root operation. This comes into play when the coder has to decide if they're going to use the root operation control or another more definitive root operation. Control is a very broad term. if you're controlling the bleeding by either of those root operations that are discussed there, then you're going to use that root operation instead of control. So if the physician says he's going to excise something or reposition something or resect something to stop the bleeding, then that's the root operation you're going to use and not control. The example that I've given you here, a patient in a motor vehicle accident, severe internal injuries, has a lot of bleeding. The surgeon finds the patient's spleen injured and bleeding heavily, so the spleen was removed. So you're going to be coding a resection of the spleen as your root operation instead of control. And here is the table we're using and the PCS code. Just as a reminder, you see the body system there? The spleen is in the lymphatic and hemic systems. Make a note, if you're not familiar with that body system, that you can recall that spleen goes here. Now, deciding if you're going to use root operation excision or root operation resection. And this particular guideline addresses those body parts that have subdivisions, like the lobes of the lung, the lobes of the liver, the different regions of the intestine. If all of that body part is cut out, like all of the sigmoid colon is removed, then that is a resection, even though you've got other parts of the colon still there. If a certain part of the liver is removed, but all of that part, and you have other parts of the liver still there, you're going to code a resection. So that's what this is talking about, when you have body parts that have anatomical subdivisions. The example given is a left upper lung lobectomy, and I have there the PCS code that you would use. And you can do that because the lungs are divided into the different subdivisions. In this case, the left upper lung. The next guideline has to do with an excision for a graft. An autograft is if you're taking skin, you've got the patient there, and you're taking skin from another part of the patient's body. That's an autograft. And that autograft is obtained from a different procedure site than the one you're working on. Then you're going to need to code a separate procedure. So the example given is the patient's having an aortic coronary bypass of the left anterior descending coronary artery and the obtuse marginal coronary artery using autologous or his own saphenous vein tissue for the graft. So the rationale is that during the coronary bypass surgery, the graft is used. It's made from tissue taken from the patient's own vein. So both the coronary bypass surgery and the procedure to obtain the saphenous vein are coded. That is called harvesting, when you have to get the saphenous vein. So 2 PCS codes are needed. The first one is the bypass operation, where you have your 4th character, the number of coronary arteries, your 7th character, where they were bypassed from. And then the second table is the harvesting or the excision of the right saphenous vein tissue. It's an excision because you are taking part of that saphenous vein, not all of it. And also you notice it's a different approach. The physician actually has a percutaneous approach to get that vein tissue. And when he's doing the bypass, it's an open approach. Now we'll talk about guideline B3.6a. This is now talking about fusion procedures of the spine. There's 3 guidelines that relate to fusion. The first guideline specifies how the body part value is determined. The body part coded for a spinal vertebral joint rendered immobile by a fusion procedure is classified by the level of the spine, being cervical, thoracic, lumbar. There are distinct body part values for a single joint and for multiple joints at each spinal level. There's an upper joints table and a lower joints table. I don't expect you to always be able to read this, but you can look in your own code book, find the upper joints table, and see what I'm talking about there for the different body part values. The next guideline is referring to when multiple vertebral joints are fused and a separate procedure is coded for each joint that uses a different device and or qualifier. You've probably noticed now there's a pattern that whenever a procedure is, even though it may be in the same body area of the body, if that 7th character or 6th character is different, then you're going to have a different code. This particular example is talking about a fusion of a lumbar vertebral joint that's a posterior approach, anterior column, and the second part of the procedure is fusion of a lumbar vertebral joint, posterior approach, posterior column. That seventh character is different, and that is what distinguishes those two codes. And the third guideline that has to do with fusion procedures talks about the combination of devices and materials. I don't try to remember this because it gets me a little bit confused, but you do whatever helps you to be able to remember this. It's right in your code book. So if you just remember that there are 3 guidelines that pertain to fusion procedures of the spine, and whenever you're coding one, you're going to go back and review those 3 guidelines before you select your final codes. I have not coded a lot of spinal surgeries, and that's why I don't have a lot of confidence in myself. So I always go back and read those guidelines over and over. I might review some anatomy books to be sure I'm understanding, especially anterior and posterior column of the spine. B3.16 talks about the decision tree, and this is a screenshot from a textbook, Fusion Device Coding, and you can see where you just follow your decision tree to decide on what device you're going to be using. B3.12, now we're going completely out of the spinal surgery, and we're talking about occlusion versus restriction. If the intent of the procedure is to completely close a vessel, the root operation is occlusion. Like if you're tying tubes to avoid a pregnancy, that's tubal ligation. Occlusion is your root operation. But if your intent is just to narrow the lumen or the opening of the vessel, not completely close it off, that root operation is a restriction. An example of that is an embolization of a cerebral aneurysm. And here's the 2 that we just talked about. Tubal ligation, occlusion is your root operation. Embolization of a cerebral aneurysm, restriction is your root operation, and the table is given there. Guideline B3.13 talks about release, how in a root operation release, it's the body part being freed that is where you're going to choose as your body part, not what you're actually moving out of the way or cutting into to free the body part. The example that's given is a lysis of adhesions. If the surgeon's in the transverse colon and the descending colon and he sees all these adhesions that are just in the way, he's going to cut those adhesions. He's going to release that colon from those adhesions. So even though he's cutting the adhesions, you're coding what he's freeing, and he's freeing the transverse colon and the descending colon. And I have there the little blue boxes showing you how you might code that. It would be 2 different codes. So because he's in 2 different parts of the colon with 2 different body part values. Guideline B3.14 is release versus division. If the sole objective is to free a body part without cutting the body part, that root operation is release. But if the sole objective is to separate or cut through or transect a body part, that root operation is division. So here you see this is release where the patient's complaining of pain in his left arm due to ulnar nerve entrapment resulting from a previous fracture. The surgeon freed the ulnar nerve from the scar tissue. You see the ulnar nerve is your body part, and there is the code that you would use for that. Interestingly, what I find interesting anyway, when a woman has an episiotomy to widen the birth canal, division is the root operation because you're actually cutting the perineum. Guideline B3.15 is reposition for fracture treatment. This is telling the coder, making a distinction between a displaced and a non-displaced fracture. If the physician repositions a displaced fracture and puts on a cast, you don't code the application of the cast. But if the cast is applied, let's say in the emergency room for a non-displaced fracture, that cast application falls under the root operation of immobilization. Now, we haven't used the section called placement yet. So far, I think everything we've done has been in the med-surg section. So this is an example of where you're using a different section towards the back of your code book, and this particular one is placement. Notice that we are in the anatomical regions body system. We've not used that a lot either, but this particular one, because we're talking about a part of the body, the patella, it would fall here. Patella, in this case, because it's immobilization, patella falls under lower leg, so the right lower leg. The body parts are different when you get in these different sections, so you just have to read them. The important thing to remember is immobilization. Well, first of all, it's a non-displaced fracture, and immobilization is what the doctor's trying to do with the cast. Immobilization is not a root operation that you can choose in all the med-surg tables. You would look under placement. Guideline B3.16, transplantation versus administration. If the surgeon is putting in a mature and functioning living body part taken from another animal or individual, that's a transplantation. If the surgeon is putting in autologous, meaning the patient's own cells, or non-autologous, cells that are not the patient's, that is coded in the administration section. So here's a different section again than med-surg. And I have there how you would code that and the PCS codes for each, the transplantation at the top and the transfusion of the cord blood at the bottom. I have a little definition there for you of syngeneic, and this is when the tissue is so genetically similar that it's not going to provoke an immune response. In this case, this patient at the top example was given his twin brother's right kidney. That's all I have for this section of the guideline. If you have any questions, let me know, and we will be discussing more guidelines in future podcasts. Thank you.